Welcome to Community Health Matters. I'm your host, Amy Marsalis. On today's show, we'll learn about infant and early childhood mental health, sun safety, and childhood obesity and diabetes. All of that coming up next on Community Health Matters.
From the News Channel 5 network, this is Community Health Matters, sponsored by the United Health Foundation.
Skin cancer is the most common cancer in the United States. In fact, you could add up all the other cases of cancer together, and skin cancer still affects more people than any other type of cancer, correct?
That is
Dr.
correct,
Rondas?
Amy, yes.
Good to have you here.
Thank you for having me.
Are the numbers, have you seen a decline since there's been more awareness, more campaigns about skin cancer?
No, in actuality, the numbers are increasing.
Really?
Yes, throughout the world. And that may be due to a number of factors, but some of that may be due to depletion of the ozone layer, because ozone helps to absorb ultraviolet radiation, which is the entity that damages skin. So we've seen numbers increasing.
All right. Tell me about the most common, let's go through the list of skin cancers, because I know there are varying degrees. Obviously, you hear melanoma, and that's
Yes.
a very scary diagnosis, can
Yes.
be in many cases. So can you go through the list?
Yeah, there are two major forms of skin cancer. There's melanoma, which you've already mentioned, and non-melanoma. And non-melanoma is divided into basal cell and squamous cell. The various percentages of them are, for squamous cell, around 16%, basal around 80% most commonly, and then melanoma around 4%. And they vary. The reason that we label them differently is based upon where they are found in the skin. So melanoma occurs in the pigment-containing cells at the base of the skin.
So
where
further down,
Yes.
deeper.
Deeper, yes.
Okay. Basal cell is more of a surface superficial.
It's at the bottom of the epidermis, and then squamous on the top, higher up.
Squamous is higher up. Okay,
Yes.
I was thinking it was the opposite,
Yeah.
basal cell higher up. Okay, I may be jumping ahead. Let's talk about, in general, how you approach patients and diagnosing skin cancer and looking for it in early stages, who may be most at risk.
When I see a patient coming in, there are a number of factors that I consider when I'm sitting down for that first office visit. Typically, we'll look for a fair-skinned individual, maybe someone from Northern European extraction, like Scandinavian countries, light eyes, red hair. These people are at increased risk of sun damage leading to skin cancers. I'll also ask about occupation. So if you're in construction, if you're doing landscaping, if you have a lot of recreational activities that involve you being outside, then it's very important to protect yourself from the sun.
All right, so if you have darker skin, more olive skin, you know, your background is more of a Mediterranean, or even if you're African American, you're not as high as at high risk.
Correct. You have a lower risk, but the risk is still there.
It's still there.
Yes, because there's really no minimum acceptable amount of ultraviolet light that you should be
Well,
exposed
not just a
to.
little color, right? That's not, you always hear people say, okay, I just want a little
I
color.
just want a little bit of a base tan, but you know, people who have, for instance, what I mentioned before about having red hair, light skin, and lighter eyes, they can begin to have sun damage in 5 to 10 minutes being outside.
Oh my goodness. Now, if you've had a burn, you had a burn when you were a kid,
Yes.
and you're now in your 40s or 50s, so what are the chances that you're going to develop something as you get older from
Blistering, yes, burns, cumulative burns, multiple burns, especially blistering burns in childhood are associated with an increased risk, both the melanoma and non-melanoma type skin cancers.
Is that because the skin just has that memory? It's just comes up over the years, moves up through the layers? I know I'm really simplifying, of course.
Right. Well, cumulative damage can occur. We call that photoaging. And when ultraviolet light, which is a highly energetic form of light, hits the skin, it causes changes in DNA. And DNA is the blueprint or the framework by which cells know how to react and build things and grow and develop. And what happens is cancer is caused, one of the ways it's caused is by damage to that DNA. It causes the cells to grow uncontrolled. And we don't want to have that happen. It's like the carpenters building your house. They go with the wrong blueprint. What happens? Your house is not going to stand. So we don't want that to happen to ourselves.
So that's where you often, you talk about like the signs, some thickening of the skin.
Thickening of the skin, redness, things that don't heal. Because cancer cells don't behave like regular cells. They don't heal properly. Bleeding, itching, pain, that sort of thing. That's what you're looking for. You're looking for changes in moles, particularly in ones that you've seen previously, that you've been following. We have something called the ugly duckling. I don't know if you've heard about that in your medical
No, I
reporting.
haven't, no.
The ugly duckling sign is, if you have 5 freckles and one of them looks different than the other one, well, that's something you should be concerned about, and you need to speak to your doctor about that.
I want to go back to the graphic. I know we had that up just a second ago. Can we look at that again with some of the symptoms? There we go. The rough or scaly red patches you mentioned. They're raised growths or lumps.
Yes,
Okay.
yes,
And then open sores that don't heal or that heal and come back.
yes.
How long should you give a spot to sort of heal or not heal? How many weeks or a couple
I generally
months?
recommend 2 to 4 weeks, and then go
Okay.
see your doctor early, because skin cancer is eminently curable if you catch it early. If you delay, and unfortunately we have seen patients who've delayed things, waiting for it to heal or trying over-the-counter medications and
Right.
things, and that causes a problem later on because of extension of that cancer into deeper layers of the
Deeper
skin.
layers.
Right.
Prevention. Let's talk about that in our final minute or so.
Prevention is the most important thing. I'm an internal medicine pediatric specialist, so I tell my parents who come in with their young children, any child less than 6 months of age should not be out in the sun. Start sunblock after 6 months of age. For the rest of us, try and stay out of the sun during the damaging parts of the day, from 10 a.m. to around 4 p.m. Wear sun protective clothing, a big floppy hat, long sleeve shirts and long pants. Those can help. And also the use of sunblock, particularly that with an SPF, sun protective factor greater than 30, reapplied regularly.
Regularly, okay. All
Every
right.
2 hours or so.
Every 2 hours or so. Probably choose an umbrella if you can find an
Yes,
umbrella to sit under.
yes.
Okay, and we've got self-tanners, and we've got, you know, for women makeup, you've got self-tanners if you want to look like you've got some color, right?
Yes, yes.
And a lot of those, I don't know that they have SPF though. So some makeup does. Just read the
Yes.
labels carefully. What's your favorite sunscreen? Can you say just what are the ingredients you need to look for?
Well, there are multiple ingredients. You need to look for one that covers both UVA and UVB, because
Okay.
those are subsets of ultraviolet light, like we talked about before.
Okay. All right, terrific.
And also wearing sunglasses protect your eyes too.
I'm
Ultraviolet
glad you
light can
threw
damage
that
the
in.
eyes. Yes.
Absolutely. Okay, Dr. Wandas, who's in internal medicine, primary care with St. Thomas Medical Partners.
Yes.
Thank you so much for coming in
thank
and
you,
educating
Amy.
us here in the middle of the summer.
Yes.
Wear the protection. All right.
Thank you very much.
All right, we'll be back right after this. Thank you so much. Angela Webster is here to talk about infant mental health, and this is just fascinating to me, Angela. Thank you for coming in.
Thank you. We appreciate the opportunity.
Oh yes, this is like an area that I have really not heard about your organization, what you're doing, and it all makes sense. And as we were discussing before the show, the research has been there for, you said 40 years or something, but let's talk about your organization that focuses on infant and child mental health and about all these neurons that are developing in
Right.
every second of a baby's life. Tell me about that.
Well, I can tell you about our association.
Yes.
We come out of about a 7-year grassroots effort of many people coming together interested in infants and young children and their families, and we were formed just about a year and a half ago, so to support the infant and early childhood mental health workforce.
Explain to us what that is and how critical child care, the people that interact with
Sure.
your baby, along obviously with parents, whoever's taking care of this child,
Right.
such early stages, how critical that is to their emotional and mental health.
Sure. So the infant and early childhood mental health workforce is basically anyone who works in a professional capacity with children under the age of 5. So we're looking at anyone from early child care providers, early education, home visiting, pediatricians, nurses. It is a vast, vast spectrum, and their role is so important because of the relationships that support babies in their development. So they support the parents, and we support the professionals.
Okay, so it says here in some of the notes I was given, early exposure to trauma and toxic stress is especially harmful to development. Of course, that makes sense. So it says, but also these babies and young children are more able to repair, learn, and grow from positive experiences than the older kids.
Right.
So expand on that a little bit for me, or maybe give me an example of toxic stress.
Well, toxic stress is stress that happens for prolonged periods of time without an adult or a caregiver that can provide some relief or some structure or some support. So it's critically important that babies and young children, and all of us, of course, but particularly babies and young children, have to have supportive adults that are attending to their needs, that are ensuring that they have strong relationships, understand big emotions. All of those things are very important.
Does some of that include just obviously the nonverbal things, the holding the baby and
Obviously.
the touching and kissing them and loving them and giving them a lot
Right.
of warm feelings? They respond to that, obviously.
They obviously do. And there's something called serve and return, which we talk about a lot in Building Strong Brains, the governor's ACE's prevention and mitigation effort. In that, there's a lot of talk about serve and return, which is where you talk to a baby, they babble back. You talk
Yes.
back, they babble back. And it's that back and forth that helps to develop strong connections and helps to develop their brains and helps to mitigate stressful situations.
So it's sort of harder to undo some of the bad influences, right? It's much easier to influence them with the
It
good
is.
versus going backwards and undoing
It
bad
is.
behavior.
So we want to start early and often with babies. We want to be sure that they have lots of supportive measures, lots of healthy relationships, caregivers that they can depend on when they cry or when they have needs or just when they're babbling and need someone to talk back.
How is mental health treated in infants and young children?
There are a variety of best practice approaches for clinical interventions. So if you are needing support for your infants and young children, you want to first be sure that you find someone who's been trained in infant and early childhood mental health. And that support is provided through the parent and through the relationship. So the parent or caregiver is always in that session or in that time with that professional who's lending assistance, and they're going to help guide the caregiver or the parent in understanding their baby's needs, in understanding their responses, in understanding their own roles. So we all have our own experiences, our own past, and our own things that are going on in our lives right now. And those clinicians and those that are trained in infant and early childhood mental health are going to be able to help determine what the impact is of me on my baby. So.
Is this something that a pediatrician could refer the parent to your organization, the Association of Infant Mental Health in Tennessee? Would a pediatrician be the one to say, hey, listen, I think, we need to guide you to these folks to help you maybe learn better practices or whatever?
They could, as could home visitors, or people can self-refer. Children that are in the foster care system, the Department of Children's Services brings in infant and early childhood mental health clinicians to assist families that are caring for those children. But we actually don't provide those services ourselves. Again, we support those professionals who do, but we know where they are in the community and across the state, and we can help form those connections.
What kind of feedback are you getting? You said you haven't been in Middle Tennessee all that long. This
Right.
started in Michigan. I
Infant
believe you
mental
said.
health was largely born out of Michigan and their efforts there. We are actually statewide, so we're not just
Okay.
in Middle Tennessee. We actually are supporting the workforce statewide, and the reactions we're getting are huge. We brought a credential to Tennessee called the Infant Mental Health Endorsement, and it's specifically for those individuals that are working in the professional workforce. And we have over 200 applicants just since November, so the response is large.
Fantastic.
Yes.
So what are some ways to encourage the positive development of infant and early childhood mental health? Give us a few tips in our final minute here.
First, pay attention to babies. Pay attention to what they're telling you. Provide support. There are lots of interactions. Ensuring that the environment is appropriate. basically attending to their needs and the relationships of the grown-ups around them.
All right, and last question, few seconds. Where can I get more information on this?
Our organization is Aim High Tennessee, and so it is aimhightn.org.
aimhightn.org. Okay, Angela, thank you so much. Very
Thank
interesting,
you.
fascinating.
Appreciate it.
All right, and we'll be back in a moment. Since the 1970s, the number of children who are obese has tripled. Just astounding. My next guest, Dr. Deanna Aftab-Guy with TriStar Pediatrics, who's an endocrinologist, is going to discuss this with us. Good to have you on.
Thanks for having me.
I know you were on one of the first Community Health Matters, so glad you came back.
Great.
All right, let's talk about this. It continues to be an epidemic in this country. Why is that? Why is it still such a problem with our kids?
Well, we're seeing more and more of it, but I think that folks are actually trying to do something about it now. Obesity is a problem, but rather a symptom of other things that might be going on, and I think that it's heavily a strong influence is our genetics, and so if we have parents that are overweight from various inherited disorders as well as lifestyle choices, and their children are at higher risk. And so in our country we are seeing an increased risk, but there are several contributors.
Well, let's talk about some of those contributors again. So some of it is in the genes, unfortunately.
Sure.
But you can turn that around, but it's a lot of work, right?
Right,
I mean, it's
right.
changing your behavior.
Right. And I talk with my kids about this. We're trying to fight our genes, and you can't change that completely, but we can affect the things that influence how our body responds to our unfair genetics. And so we address the diet, number one. We address their body's activity level. What are they doing to move their body? And lifestyle in general, as well as addressing medications and evaluating them with physical exam and laboratory assessment to see if there are other things that are contributing to their difficulty in maintaining a healthy weight.
So how can a parent tell when a child needs to see someone like you, a pediatric endocrinologist, that's a mouthful, and when there might be a hormone issue?
Well, number one important factor is to see your pediatrician. The child should have a primary care physician that they see regularly. We take our baby to the doctor every few months for vaccinations, but once a child reaches a certain age where the vaccinations are pretty much set and they start going to school, they tend to go once a year, maybe every few years, and they lose touch with their pediatrician. And we're starting to see increased obesity in children at younger and younger ages. If they are weighed and measured at their pediatrician's office each time that they're visited, and they talk with their pediatrician about all aspects of their child's health, including their growth, height, and weight, the pediatricians are very keen on this, and they will determine if the child truly needs just some simple interventions or an evaluation, or to be referred to a center that has several folks involved in a team that addresses these issues.
How is treating a child for obesity or one of these related conditions related to the obesity, how is it different than treating an adult?
Well, it's a good question. We have a team that addresses the dietary needs. We have a medical nutrition therapist and we have a physician, but we also talk about activity level. I think when an adult goes to their physician, a lot of times they don't always have available a nutritionist or dietitian, and that tends to have to be referred to separately. Also, the adult providers don't always have as much time to be able to focus on those issues. I think when you get to a subspecialist and the appointment's centered around that weight management, we tend to really jump on it as a team. So we do a thorough history, and I set up a separate consultation with our nutritionist, and my patients spend up to an hour and a half, sometimes 2 hours with our nutritionist. And I always tell them, I don't care what medicines I give you or how much time I spend with you, the reason why that child achieves a healthy weight eventually is because of my nutritionists. They're amazing. I think that they meet the family right where they are. We're not going to put them on a kale diet, as I tell them. They're families that have limitations based on financial needs or dietary preferences or allergies or what the rest of the family is going to allow to be brought into the home. And our nutritionists are excellent at hearing what they're able to do and tweaking it so that it can be healthier and benefit that child's health.
That's a good chunk of time too to spend with a nutritionist.
Oh,
I mean, you can
yes.
pack a lot of information in that amount of time. That's wonderful. What are some of the health risks associated with childhood obesity?
Things that we know as adults at being overweight. Children are at risk of developing diabetes at younger and younger ages. Type 2 diabetes, we're seeing at younger ages. They can have heart disease, elevated cholesterol that can lead to further heart disease, and then later on in life, strokes, joint problems, just overall inactivity because their weight and not feeling well.
And that's heartbreaking when you realize that had something been done when they were younger, someone intervened, nutritionists and someone to coach them on better choices and things, or if there is a hormone-related problem to get to that. Help us understand the difference too between type 1 and type 2 diabetes in kids, and what are some of the symptoms?
So diabetes is elevated blood sugar. Type 1 used to be called juvenile onset, and that is when our pancreas, the part of our body that makes insulin, that stores the sugar for us for a fuel, the pancreas stops making that insulin entirely. It's an autoimmune disease, meaning our body attacks that part of the pancreas and makes the insulin. And without insulin, the blood sugar rises and cannot get into the cells. It's typically inherited, although you can get type 1 diabetes without any family history of it. And it's treated with insulin. These are the children that we know of that have to check their blood sugar and take shots and be managed carefully. Type 2 diabetes we used to think of in our grandparents and adults, and they still make insulin, and it's not an autoimmune process, but rather the receptor for the insulin is resistant, and it can be exacerbated and worsened by rapid weight gain. So you tend to inherit a tendency to develop it. You have to be that person that tends to needs to eat better and be more active, and you make too much insulin but don't manage your sugar well with it.
Okay, thank you so much for your time, Dr. Guy.
Thanks.
Thank you for watching Community Health Matters. Learn more ways to improve your health on our website, mycommunityhealthmatters.org. And remember, here in Middle Tennessee, our community health matters.